This webinar is sponsored by COSOFI, and so we've got a lot of folks joining from a lot of different backgrounds. If you requested CHEDS credit, you should have gotten some information on that. There'll be evaluations to fill out. As a reminder to everyone, we'll go ahead and email the full slides out to everyone after the meeting has ended, so just check your inbox for those slides. They'll come in PowerPoint format. During the webinar, if you have questions for us, please go ahead and use the chat function on your screen. If you're having issues getting through to that, let me know. It looks like it wants you to re-register again. It's just, you just have to input your information. It won't charge you again or anything. And it's so that I can see who's live in the online format. So please go ahead and do that. And then I know that we'll do questions at the end, certainly. And if anything urgent comes up, just use the chat. And with that, I think we're good to go. Kristen, are you ready to roll?
Sure. Will do. Well, hello everyone. Thanks for joining us, and thanks to Lindsay and COSOFI for hosting this. I really appreciate it, the opportunity to talk to all of you. I'm going to go through and talk a little bit about what we mean by care transitions. I'm going to give you a background on my organization, talk about care transitions, and then introduce you to the initiative that we're here to talk about today, Healthy Transitions Colorado. I'd like to also go through some of our resources and then talk a little bit about where we're headed in the future. I realize that given the variety of backgrounds, some of this information might be a little bit basic for some of you. Just bear with me and we'll get through it. I want to make sure everyone's on the same page as we go through this information. So first of all, a little bit, oops, I have to hit the right buttons. First of all, a little bit of background on CIVIC. We're the Center for Improving Value in Healthcare. We were originally established in 2008 as a brainchild of the Blue Ribbon Commission for Healthcare. We provide support, facilitation, data, and leadership to a variety of healthcare actors and facilities across the spectrum, across the care continuum. We are an independent nonprofit, so we used to be part of the state. We are no longer part of the state. We are now an independent nonprofit with no partisan connection. And we work essentially on trying to improve healthcare. That's our goal. And we work across multiple sectors. We work in the private sector, public sector, with individuals' health plans, and we really are trying to build consensus and drive collective impact to reach the triple aim for care in Colorado. So we have three key initiative areas. Data and transparency is the first one. And we have developed statewide triple aim metrics to really measure the state's progress on improving care, improving health, and reducing costs. We're also the state-appointed administrator of the Colorado All-Payer Claims Database, and that provides cost and utilization data for commercial and public payers across the state. And much of that data is publicly available on our website at cohealthdata.org, so you can use that as much as you like for your organization. We also have a payment reform group that are working on driving value-based payment rather than volume-based payment. We have an internal goal of reaching population-based global payment systems by 2018. We're kind of known for being a bit ambitious, but we are working diligently with payers across the state to really move towards those bundled payments. And then we work in delivery system redesign, and this is the area that I focus on. We work in palliative care. Palliative care was identified early as an opportunity to really hit those triple aim metrics and improve care, improve quality, and really reduce costs across all ages and all patient groups. We also work in care transitions, and that's where we have created Healthy Transitions Colorado with the partnership of some wonderful groups across the state that we'll get into in a little bit. Our vision of the triple aim: better health, better care, and lower costs, all facilitated by data and transparency to support that change. So that's CIVIC, and then I wanted to do some background on what care transitions actually are. So when we talk about care transitions, there are a couple of different things that may spring to mind. Care transitions can refer to the aging out of patients from pediatric to adult services. Care transitions can refer to the movement within a hospital from department to department. But the care transitions that we're really focused on are the movement of patients from one care setting to another. So going from a hospital to home, or from hospital to home health, or a SNF, or a rehab center. So we're really looking at that inter-facility transition, not the intra-facility transition. So care transitions involve many different care settings, and they can involve the patient's home. A lot of times the focus is on the hospital setting and moving from the hospital to home or home health, but there are a variety of other settings that can also impact a care transition. Movements from home to rehab or to a nursing facility can also be a very dangerous transitional time. The danger comes in that each shift in care brings a new primary caregiver and new information and perhaps lost medical records and issues with communication. So here's some of the consequences of poor care transitions. So 20% of all patients that are moving from the hospital to home, so this is just looking at that one transition from hospital to home, 1 in 5 patients across all age ranges, we're not limited just to Medicare here, 20% of all patients experience an adverse event within 3 weeks of discharge. And an adverse event is defined as an injury resulting from medical mismanagement, not the underlying disease. The most common adverse events are medication related, so either hospital medication errors or a failure to do a medication reconciliation. But 1 in 5 patients experiencing an adverse event due to some kind of mismanagement. Almost 20% of Medicare beneficiaries return to the hospital within 30 days of discharge. Again, 1 in 5 Medicare beneficiaries. And then this is having a huge impact on our costs. For Medicare alone, readmissions account for $26 billion in spending every year. Latest estimates are that $17 billion of those dollars are preventable. So when we're talking about readmissions and going back to the hospital of a care transition, we're not talking about medically necessary readmissions. If you need to go back to the hospital because of a complication, by all means, go back to the hospital. But we're talking about preventable readmissions that are due to medical mismanagement, to a lack of care coordination, or a shortage of social supports and basic necessities, such as food, ability to pay for heat, or someone who's physically there to help you do your activities of daily living. So what does this matter to public health? Sometimes this can be a difficult way to look at care transitions, but right now our 65 plus population is the primary source of readmissions, and they're the fastest growing population in this state and really in the country. So this aspect of care, these care transitions really have an impact on the overall quality of elder care and the quality of life of an entire population of individuals. The care population is also impacted through missed work days, stress-based illnesses. This population is often overlooked. There's not a lot of attention that's paid to the caregiver population, but there have been some studies out there that show an alarming correlation between the stress of having to be a primary caregiver for a loved one and developing a serious illness not long after. It also has a huge impact on the workforce and on just overall missed days and quality of work that's happening out there. And then finally, the potential cost savings is incredible. By keeping folks out of the hospital who don't need to be in the hospital, we can allow for higher quality care and increased resource availability for those who do need to be in the hospital. Finally, community engagement is also a huge piece of care transitions. Just by the nature of being a transition, it moves beyond the hospital walls and has to be community-based. We're talking about someone leaving the hospital and going to another setting. So that, by definition, brings in our community. Studies showing the efficacy of community-based versus hospital-only transitions have shown there's just very little comparison between the two. The efficacy of community-based transitions is much, much higher. And all parts of our care community can really play a role in this, whether it's social supports, faith supports, medical home care, public health, the whole shebang. Which brings us to Healthy Transitions Colorado. So Healthy Transitions Colorado is an initiative that Civic launched in July of this year. And I think I'll talk first of all about why we decided to create this campaign and give you guys some background on what we've been doing. So in 2010, early 2011, the Centers for Medicare and Medicaid Services announced that they were going to start penalizing hospitals for excessive readmissions. The first year of the penalties were going to be 2012, and it could be up to 0.5% of their Medicare reimbursement. That potential penalty was going to increase over years until it hit, I believe, 3% of the Medicare reimbursement for these hospitals. And that was based on whether they had what was considered excessive readmissions. So a risk-adjusted determination of how many admissions would be reasonable for that hospital, and then if they went over that number, they would be penalized. Readmissions were a clear target to advance the triple aim for CMS, and they were costing the country billions of dollars in potentially avoidable readmissions. Care transitions are a clear and direct means to avoid readmissions. And many hospitals became focused on improving their care transitions in order to reduce their readmission rate. Once the hospitals became focused on trying to get these numbers down, the states started to get involved as well. And we started seeing programs like Rare Readmissions in Minnesota, which is a statewide campaign to reduce readmissions. It's run by the State Hospital Association and the QIO and the Quality Improvement Organization for the state. And they work with everybody to create a coordinated, common methodology and goals and move everybody along the same path across the state to reduce readmissions. They've been very successful at this. Other projects like No Place Like Home, Florida is another example of a QIO really bringing the whole state along on this readmissions reduction path by improving care transitions. Here in Colorado, however, we already had many strong programs that were dedicated to reducing readmissions. Hospitals, private, public, urban, rural, everyone was already working on the issue. And it seemed really strange to think about starting from scratch to create a common methodology along the lines of Minnesota or Florida. So we brought together a multi-organizational collaborative in late 2011 to start talking about what was happening with care transitions in Colorado. What was happening, where it was happening, what kind of gaps existed, what needed to be addressed. We had over 40 organizations that really came to the table and brought a lot of information about what was happening. By mid-2012, we'd really decided or found that while there was a lot of work being done, there was very, very little communication. There was a lot of duplication. There was a lot of excessive and wasted effort on things that may have been done by a facility literally just down the road. So we really needed a way to improve communication and collaboration across the state. So in late 2012, the task force pulled together a planning committee that then chose our operating partners. And our operating partners were major players that had on-the-ground efforts statewide to improve care transitions and reduce readmissions. And that was CFMC, the Colorado Hospital Association, the Colorado Healthcare Association, and the Colorado Rural Health Center. And those four operating partners have been pivotal in getting this campaign up and running and have been pivotal to the day-to-day operations. So Civic acts as a managing partner. We manage the website, we manage the campaign, but all on-the-ground work and all subject matter work is done by our operating partners. So the mission of Healthy Transitions Colorado, you can read it right there, we're focused on fostering collaboration, sharing best practices, supporting efforts to reduce readmissions, and helping to break down silos of care that are preventing true community care coordination. So our focus was very much on collaboration and communication, creating those communities of care. We have no specific methodology that anyone needs to follow. We're just there to give information and help people make those connections, to figure out who's doing what and who can I talk to so that I don't repeat work that's already been done in the state. So our goals, this is a 2-year campaign that we've established. Our campaign goals are rather ambitious. We sat down with the planning committee, and the planning committee unanimously decided to use the CMS goal of a 20% reduction in readmissions over 2 years. So for Colorado, that means eliminating 4,350 readmissions each year, or 8,700 admissions over the course of the campaign. If we succeed in that goal, we'll eliminate 34,000 days in the hospital, and we'll save over $80 million in healthcare costs for Coloradans. So we have a number of steps that we're going to be taking to reach those goals. Obviously, this is not something we can do in one big push. So we're conducting educational webinars. We act as a gateway to different local and national resources to improve care transitions and outreach to your community. We connect local partners across the state. We will be having a newsletter of events that's starting in January, and all of this is accomplished through our website, which is really our portal for all of the services that we offer. Oops, wrong button, sorry. There we go. So this is a snapshot of our homepage. It's www.healthytransitionscolorado.org. And this is sort of our landing page where everyone starts. We actually just a couple years ago, I have to brag for a minute, just won an award for our website. We got a Bronze Leaf Award for websites under $15,000. And we like to joke that if they knew how far under $15,000 it was, that we would have gotten a Gold Leaf Award. So this is where everyone starts. There's an About Us section, and then ways to get involved, ways to pledge your participation with the campaign, and then various resources and information about our progress as a state. So this is a snapshot of our metrics dashboard. This is where we keep track of the various readmission rates for different populations across the state. At this moment, the dashboard includes the readmission rate for both commercial and Medicaid, and then Medicare. These rates tend to be very, very different, and they are also tracked separately, so we wanted to report them separately on the website. So the hospital readmission rate, the hospital readmission percentage, the admission rate, because we found that a successful readmission program, a successful program to reduce readmissions, also happens to reduce the admission rate. And so we want to make sure we're tracking both of those numbers so that we can adequately represent the progress that our facilities are making. We're tracking emergency department visits, and what you can't see on this snapshot is that we also track the discharge disposition. So where people are going from the hospital. Are people going to hospice? Are people going to a skilled nursing facility? Are people going home? Where are people heading when they're discharged from the hospital after an acute visit? So you'll see these numbers here for commercial Medicaid is 9.5% and Medicare is 15.7%. These numbers were from late 2011. Our numbers have now decreased. Non-Medicare, so the commercial Medicaid is right about 9% exactly, and Medicare has dropped to under 15%. So we're looking at close to a full percentage drop in less than a year, which we're very, very proud of. Not that Healthy Transitions is not on the ground. We didn't do this. All of our partners have done this. I just want to be clear about that. This is the work that our partners are doing and the work that our partners are supporting. We're just there to help them make connections and support the work they do. So here are some of our resources. We offer monthly free webinars. You can sign up on our website and you'll get invitations to the monthly webinars. We started off with a webinar hosted by Cedars-Sinai out in California about partnering with home health to reduce readmissions, so strengthening that bond between hospitals and home health. We then had a webinar on Project RED, which is a readmissions campaign, and the Safe Transitions Collaborative. This is something that the Colorado Hospital Association was working on in coordination with United Healthcare, and they made some very impressive reductions in readmissions in certain populations. And then this month, we had a webinar on long-term care and nursing homes, which was another just really great insight into some of the connections that need to be made coming out of the hospital. And then coming in January, we will be launching our newsletter, which will be a monthly grouping of all the events that are happening around the state and ways for you to get connected and find out what's going on in your community. So here are our upcoming webinars. In December, we have a webinar on iCare, which is the readmissions reduction program being used by the Colorado Rural Health Center to reduce readmissions in rural parts of the state, and some of the successes that they've had over the past 2 years. And then in January, we're going to be talking about the All-Payer Claims Database, which is our database here at Civic, and how that data can be used to support readmissions reduction and improving care transitions. Other upcoming webinars at the beginning of next year, we're going to have a webinar on community supports, so outreaching to non-medical elements of the community that can support reducing readmissions, health information technology and its role in this, telehealth, palliative care and hospice, and then the federal CCTP project, or Community Care Transitions Project, that is funded by the feds. Colorado was lucky enough to get one of those grants. And currently, the Denver Regional Council of Governments in downtown Denver and the Area Agency on Aging are running that program to reduce readmissions among a specific Medicare population. So we're going to be hearing from them in a few months as well. This is a list of some of the tools and interventions that we have on our website. They're available to anyone. We have assessments, we have checklists and patient aids that you can use. Many of these have been developed by local communities, so they may be tailored to their population. We also have information on interventions. We have some how-to guides. We have a grid of evidence-based interventions that you can use to access different kinds of major programs across the country and find out what might be best for your facility, and then also some of the local programs that are happening across the state. So this is just our resources main page, and it gives you access to all of the things we just talked about. And I think really our strongest resource, our best resource, is the community. It's our network of partners. We're very close to 100 different partners from all across the state, including the ones that you see listed on this slide and many, many others. And these community partners have pledged to connect and be connected with others across the state. Our partnerships have helped bring together many different groups and have really improved the quality of care that's given in different parts of the state and helped provide a safer, more supportive environment for patients. So once you pledge, once a facility pledges to be part of Healthy Transitions Colorado, and CDPHE, HCPF, a lot of government organizations across Colorado are also part of our campaign. And once you pledge to become part of our campaign, you're added to our map. Your logo is also put on our website along with a link to your page. But this map is really my personal favorite resource that we have through the campaign. So each one of those stars, and this is from quite a while ago, it's just a little clearer to see on the snapshot. Each one of these stars represents a facility that's pledged to be a community partner in Healthy Transitions Colorado. And they've provided a contact person, an email, phone number, their website, and then a brief snapshot of what program they're using at their institution. So if you're just getting off the ground, or let's say you're starting in on Project Red, you can look up different partners on this map and see, okay, here's Exempla Lutheran. I'm going to go ahead and give Betsy a call and see if she can help me figure out how they got off the ground with Project Red, what kind of success they had, if she has any tips for getting going. And these connections have really been very, very helpful for people and have allowed folks to really create some of these communities to support people coming out of the hospital. So that's what we're doing right now. We have some interesting information that's going to be coming out that we're hoping can support further work in care transitions. So this right here is a snapshot of some of the information that will be available next month on the All-Payer Claims Database. There's a big focus on readmissions in our new data release. And for example, this gives you a county-by-county comparison to see how your county is doing on readmissions compared to the rest of the state. You'll notice at the top the illness burden score, and that's basically a risk adjustment to let you know, is your county sicker than average, healthier than average, where does your county sit along the continuum in the state, and then it breaks it down. So where are all of those readmissions coming from? Are they coming from behavioral health? Are they coming from neurology? which branches, which service lines really need your attention to make sure that your population is as healthy as can be. We also have another table that's going to show you what percentage of each of those service lines goes to, becomes a readmission. So you'll have an idea. That'll sort of even out some of the smaller service lines so that you won't have disproportionate numbers all over the place. So this next slide, this is a image of the different DRGs that Medicare is focusing on. So right now Medicare only judges readmissions based on heart failure, acute myocardial infarction, and pneumonia. So those three DRGs are what's tracked. And this gives you an idea. We actually have the wrong first line there. Don't pay any attention to the first line because that's pacemaker implant. This gives you an idea of where we're sitting as a state as far as our readmissions percentage. So our heart failure readmissions is sitting at just over 17%. And pneumonia is sitting at around 8%. So these are really great opportunities for us to target large populations and make sure people are being able to stay at home. In 2015, CMS is going to be adding COPD, hip joint replacements and knee joint replacements to the readmissions that they're tracking. So this just kind of gives you a picture of where we're sitting in the state. And again, this information is going to be available to everyone on our website. So we have some remaining challenges in care transitions. There's a lot of work that still needs to be done. EMR interoperability is a huge obstacle right now to improving care transitions. Trying to find an interoperable system that works from hospital to nursing home to home health to rehab is very, very challenging. It becomes more challenging when the meaningful use requirements for electronic medical record adoption only extend to physicians. Patient and caregiver provider education. A lot of this is just information. Providers don't necessarily think outside the hospital walls. And there are some basic questions that can be asked that can make the difference between a readmission and a non-readmission. So do you have food at home? Do you have the capability to pay your electrical bills? Some of those social determinants of health can be covered in just a couple questions and the connection to some of the community services the hospital works with. Likewise, social support systems, transportation. Can you get back to the doctor for a checkup or for a prescription refill? Medication reconciliation. This one should be straightforward, and yet it's still one of the most problematic areas that we have, making sure medications don't have reactions with each other and that dosages are correct. And then there's always the workforce issue too, because care transitions require a lot of man hours from the community, from the hospitals, from the healthcare facilities. It's a lot of man hours to train and to actually have these supports in place. And currently, the reimbursement system does not reimburse for those hours. So we're at kind of an impasse. It's a little challenging right now to find ways for people to get the manpower, get the structures in place, and get it paid for. Especially in communities and non-hospital or non-medical situations, it can be very, very challenging for them to get reimbursement for the time they spend working on improving care transitions and reducing readmissions. So the other piece that we are working on as Healthy Transitions Colorado is a rural outreach program. We're currently waiting right now to hear on a grant that we have in process to see if we can start reaching out to some of the rural communities. And we hope to be able to do that in the spring and travel out to some of the communities that aren't able to be in Denver to really help them do a gaps analysis and help them take a look at what's happening in their community and how they can work with each other to improve the efficacy of the projects that are already in place. So that's about it. I've got is the Healthy Transitions Twitter handle and our Facebook page. We actually have quite a few Twitter followers, so I encourage you to follow us there and really join us as a community partner and pledge your commitment to helping us reduce readmissions and really improve the health of the entire population. That's all I've got right now. Here's my contact information. Are there any questions?
Lindsay. Kristen, can you tell me about what work you guys are doing, if any, coordinating with RICOs and any partnerships you see on the horizon?
Sure. So right now we are working, I believe, I'm trying to remember which numbers. I know, so Rocky Mountains, RICO, I think that's 1, 3? I can't remember which number it is.
I'm trouble remembering the regions too.
They've been with us from day one. A lot of the RICOs are looking to us to identify some of the community partners that they've missed, especially some of the larger RICOs, either population-wise or geography-wise. Rocky Mountains RICO is huge, physically enormous, and so they have a tough time actually figuring out what supports are out there that they can use within their structure. The ones here in town, Colorado Access is also another partner of ours, and they are working with some of the more urban populations, and they also, with that large number of people, they've got some challenges figuring out what's available in this community and how can they leverage that to make sure that folks are getting the care that they need. So we are working with them pretty closely. Any other questions?
Folks, you can jump right in with questions. Just be sure to unmute. You can chat them, and while we're waiting for someone else to have a question, if any, I want to remind folks of a couple of things. Please join COSOFI on social media. We're on LinkedIn, Facebook, and Twitter. And if you follow us on any of those sites, you'll see information about upcoming webinars. So for example, our next webinar is December 10th. And that webinar registration is currently open. So you can contact the Alliance through your usual path. You can click on a Facebook link. You can do a lot of different things to sign up for that. There will be CHES credit available. And as a reminder, you're going to get evaluations in your email inbox. For those of you seeking CHES credit, you have to return them. For everyone else, we would just love it if you did. And you'll also get a separate email with the slides available from today's presentation. So that's kind of my housekeeping. Now that I've done that, has anyone come up with a question or anything else for Kristen? Okay, well, hearing none, thanks so much for the webinar. We really appreciate everybody's time today and for joining us. And Kristen, thank you.
You're welcome. And please feel free to contact me if you come up with questions or just kind of curious about anything else that we're working on. My email and phone number are right there, and please don't hesitate to give me a call. Thank you.
All right, lots of clicking. Anyway, thanks. Have a good day, everyone, and we'll be in touch.
All right. Thank you, everybody.
Bye.
Thank you. Please stand by.